So the topic and theme that we're going to tackle right now is the criticality of certain factors to make success in this area of health informatics, and really to talk about what are the best models for embedding within the healthcare space to actually be purposeful, practical, and effective. So if I could just go through a certain round of introductions here. Here we go. So we have Professor Louisa Jorm. She's an epidemiologist and data scientist and recognized around Australia as a leader in research using large-scale, routinely collected data. She's foundational director of the Centre for Big Data Research in Health at the University of New South Wales in Sydney. And prior to taking up this full-time academic post in 2007, she'd spent more than 15 years in government roles and other service roles, including 10 years as the director of the Centre for Epidemiology Research in the New South Wales Department of Health. So a huge experience that we'll be tapping into this morning. Her experience in these senior leadership roles in government and now academia really gives her that combined insight into how best to bring the sectors together. The Honourable Greg Hunt, in many respects, requires no introduction. He is an honorary enterprise professor from the Chancellery of the University of Melbourne, appointed to both the Faculty of Medicine, Dentistry, Health Sciences, as well as the Faculty of Business and Economics. Greg is also the inaugural chair of the Advisory Council for the Turner Institute for Brain and Mental Health at Monash University, and will be the inaugural chair of the Faculty of Medicine, Dentistry, Health Science Advisory Board. He currently advises a wide range of businesses and not-for-profits in the area of innovation, leadership, strategic planning, health, and the environment. And he really showed the impact of his work over the last number of years with COVID, with his deep passion for research and data through his stewardship of the MRFF, as well as the inception of the digital environment in research. The other speakers have had a good opportunity to tell us a little bit about themselves and the impact and their passions in that area. And I thought I'd just invite Greg to share with us for the next 3 or 5 minutes, just the major things that wake you up, keep you awake, make you leap out of bed with joy in the morning.
It's a fairly broad offering, Peter. But in particular to Claire and Michael, to Louisa and Peter, to Wendy and to everybody here, I'll start with a completely different place. We're actually in the law school. We're in the Woodward Centre. The Woodward Centre is named after a great Australian jurist, Sir Edward Woodward, Ted Woodward. Not only was he a Royal Commissioner into crime on the waterfront in the 1970s, he was one of my brother's godfathers. So he and my father went through law school together, and I remember Ted's lesson to me was always that even though he was dealing with the heaviest of crimes and the most weighty of things, that the law always had to have a human face. And it's the same with data, that as you look at all these challenges, as the minister responsible for the national framework, the question we always asked was, what does this mean to the individual patient? And so as we look at embedding research, let me give a slightly different perspective to the others, which is the overarching meta picture, but then how that relates to individuals. And I think there are 3 pillars at the national level that can help you in your work. Firstly, we put in place the data resource itself, which is only one of, millions and millions of data sets, but having a national data set with the My Health Record, international visitors would often say to me, you've got over 90% of the population, we've flipped it from being opt-in to opt-out. And so that is, as I was discussing with Graham Hart, a pregnant capability. It's being used, but it's not anywhere near what it could be. And that's a combination of, on the one hand, of input. 90% of a developed state population signed up, but we need to have greater inputting into it through, in particular, many of the hospital systems. Victoria is better, some states are worse. But to be able to work across each of the jurisdictions on that front, so as every system is integrated and talking, that was the final brief that we gave to the Digital Health Agency. But that's an enormous resource. The second element there, though, is what's drawn out of that. And this is where the funding option of the Medical Research Future Fund is a huge capacity. It's a $20 billion fund, it's $650 million a year. It's across the 4 pillars. And Peter, the thing that is really prospective and which has not been as utilised yet as it could be is the capacity to build digital design and research into the applications. So the 4 pillars are patients with a big focus on clinical trials. That's got an element to it, but specific broad-scale clinical trials for rare cancers, rare diseases and unmet need has a huge opportunity. The second pillar is the clinician side with a focus on frontier or breakthrough medical research where there is the scope and the capacity to put large data analytics into program design. The third, which is the most prospective, is commercialisation and translation. And in particular, one of the programs under that pillar is the National Critical Infrastructure Program. And data was what we meant by that. So there's $650 million, which is the least allocated part of the Medical Research Future Fund. It's all peer-reviewed and competitive. But working with the Federal Department of Health on the design of sub-programs within that national critical infrastructure, there's a pool of money designed and intended exactly to address some of the problems you're negotiating, but where you have the opportunity to help frame that structure. And then the last of the areas under the Medical Research Future Fund are the 8 missions. They're specific national priority missions, but the 2 big data ones are stem cell missions, the stem cell mission, and in particular the genomics mission. And you understand better than me the enormous collective but individualised data which comes out of each of those. And they're between them $650 million over 10 years, and they're both chaired by people along the along Flemington Road in terms of Melissa Little and Catherine North. So that brings me to the last part, which is how do you actually translate this? You always need to have a regulatory partner because of the data security, and the Digital Health Agency exists not just to administer my health record, but to help translate your research into actionable items. And so their other legacy task or forward-looking task is to take ideas such as real-time prescription monitoring and to make them reality. That's an example of something which has occurred where data is being used to protect and help patients and to protect and help the system in real time. And the Digital Health Agency, I think you ought to look, Wendy, to set up a permanent engagement between the academic community and the agency on your research and their needs, and I think that would be a forward step. So that's a little bit of the differing perspective of what I'd call data with a human face.
Thank you very much, Greg. That's really important for setting the scene, because what it does is it highlights to us the complexity of data at so many different levels, from the collection to the management to the oversight and governance of that. And Louisa, in your role as the Director for Big Data Research, what sort of navigation buoys do you have to look out for when you're trying to interact in the health system, be it the broader health system or institutional health systems?
Look, there's a huge number of navigation buoys, but I actually wanted to say something a little bit in response to what Greg just put forward. And it sort of relates to the earlier conversation as well, where we talk about patient data, its primary purpose being to support patient care. But then there are these, what we call secondary uses. And I actually think that language is not very helpful. And it has resulted over the years in the idea that there are these other uses, these uses of aggregate data for research and for quality improvement and for action to improve populations of patients rather than just at the bedside, the one patient, has always been a bit of a poor relation and thought about second, and hasn't actually been considered in the design of systems. My health record would have to be said to be an example of one of those, where it's very difficult to actually get, I think impossible basically, to access that data for research at the moment. But there are lots of other examples. When I worked in New South Wales Health, sort of on a yearly basis, they looked at what data items were being collected in their admitted patient, administrative data set, which is basically collected for funding related purposes. And I kept advocating for smoking and body mass index, which are just really, really basic things if you're wanting to use that research, that data for sort of research purposes. They're sort of universal, really important confounding variables. I never won that battle. They've never been collected. But similarly, now I work with electronic medical records from hospitals. It is extremely difficult to actually get them out of the back end of the systems. In New South Wales, we mainly use Cerner Millennium. There's a specific proprietary language, CCL, which is used for extracting data. We have 7 different Cerner domains across the state, so you can't use a single set of those CCL scripts, even when you've got them, across each of those 7. You've got to go out to each one individually and write a new script.
So what you're saying is the navigation is tough.
Yes, but I also want to say that there are some positive developments. So in New South Wales, they're now developing something called a single digital patient record, which is meant to cross both primary care and the hospital system. But surprisingly enough, right at the beginning, they've actually set up a sort of I think they're calling it a secondary uses and research advisory working group, which is starting up right now. So they are thinking right at the beginning about trying to bake into that system what we need to pull the data out of it and to actually get value out of that aggregate data.
Thank you. So Mike, one of the first places in the world to have EMR and to use data, things like that, what are the navigation points you would advise to look out for today if people here in Melbourne, for example, are starting to develop EMRs, use EMRs, early phase, we've got a university with a centre that's really powered to do something. What would you ask them, advise them to look out for in bringing them together?
Well, I would go to training almost immediately. I mean, it's this issue of if you don't understand and you don't speak the same language and don't understand the problems and the pressures, you'll just be crossing as ships in the night in the fog. And learning each other's language, learning each other's challenges, the idea of embedding someone in for a short stay, a short fellowship. When I moved over to have a joint rollover in the health system, I was just amazed I just never fully appreciated the incredible pressures that those organizations, their priority list of high priority projects always greatly exceeds their budget. Always. It's always 3x what they can, they're all considered high priority. And I just never appreciated that kind of pressure that is constantly there. So I think the number one navigational point that I would say is take the time to live the life of the other side that you're trying to collaborate with and navigate. So the university having, they talk about having fellowships of healthcare organization members come and take the courses. It should be the other way around, too. University folks should do internships in the healthcare organization and live that life and go both ways. I think that would be, just language is just so important. It will reduce a number of barriers.
Yeah, Claire, you've lived both sides. You constantly live both sides, and you were one of the first to introduce that in this country. Give us your experience about that.
It is so rewarding. It is honestly my life's privilege to work across two. It gives you the ability to understand the pressures that the healthcare system provides. It gives you the opportunity to speak to consumers who are ultimately affected by the work that I do. But it also gives me a unique insight into how to access funds for innovation and R&D that don't involve me going to an overstretched hospital CEO and asking for money. So I really think we need a clarity around who does what and who funds what is operational analytics, what is R&D. And then from that, we can understand who funds what. So if it's an operational analytics that helps the hospital run better and deliver better, or I would argue that's operational funding that should come from the state. If it is actually R&D, blue sky thinking, and we are at the frontier, as our honourable friend says, that's the type of thing that's R&D, the same way research into vaccines or drugs would be. And so our funding source for that would be, indeed, MRFF and NHMRC. So I think in our country we potentially haven't articulated that well. It's not clear who does what. And so I think we probably need a national conversation, and Greg, we'd be delighted for you to join us in that, about research funding and digital health, who does what, who pays for what, so we can get some clarity and put this into action.
Greg, do you have any response to that?
Yeah, sure. So the first thing is the NHMRC, so within the Australian context, Mike, that's peer-reviewed, competitive, scientifically reviewed, bottom-up, investigator-driven. The Medical Research Future Fund is still peer-reviewed and competitive, but it's top-down national priorities, consciously designed to allow systemic problems to be addressed in that way. As part of that, as I say, we expressly carved out the National Critical Infrastructure Program within translation.
I have to thank you for my grant.
Sorry?
I have to thank you for my grant.
Oh, there you go. There you go. But that has a very significant component that was deliberately unallocated. And so there's program design. So that's the opportunity area.
Yeah.
To be with the Department of Health and to enlist the Digital Health Agency to be an ally in the development of that. So I'd get Research Australia, Universities Australia, Council of Medical Deans, that group together with the MRFF and the Digital Health Agency.
I agree.
Yeah, Louisa?
I won't thank you directly for my grant as well, but that's
Everyone who's missed out will.
But those research infrastructure grants, and I've also got 2 grants through the cardiovascular mission, both of them, so which were both data related. So the MRFF certainly has been, I think, a fantastic new vehicle. NHMRC, it's extremely difficult to get funding for this type of work. I've also found MRFF to be a bit more risk-taking, going for things that aren't, just a little bit out there, people whose track records don't necessarily look like an NHMRC track record. But one really important thing is that it's got a very strong emphasis on your lived experience, community and consumer engagement. And the first time that I had to write an MRFF grant, I was like, oh my God, I've got to write a whole page about how I'm going to do this. But I think it has changed the way researchers are thinking about this in an extremely positive way. And there's also been, on the panels which I've been on and chaired, there's consumers who actually operate as full members of those panels. They're not just someone who sits in the corner sort of taking notes or ticking off a checklist. They're actually participating as full members. And I've just found that to be a fantastic advance that the MRFF has driven.
Thank you. Questions? Yes, please. Here comes the microphone. Please stand up and introduce yourself and ask your question.
So my name's Shiv. I'm a clinician at the Royal Children's Hospital, and a question was, we're talking a lot about the value of collaborating and embedding and things like that, but I guess my question is about what do you think we can do within our own organisations, particularly within hospitals, I guess, because that's my background, to prepare ourselves to be the best collaborator? Because I think maybe Graham was maybe asking a little bit about this earlier, like that you want to have a certain culture so that when someone comes in, it's a seamless relationship. So what can we do to prepare?
Over to you first, Claire.
So I think we have to understand, and this is hard for many academics, that actually the health system is the dominant partner. They actually are. They are looking after people and saving lives every day. And so as someone that straddles the both, I have been communicating that message very clearly and it's getting through. So really the hospitals are the ones that are up all night, 24/7, saving lives. ourselves in the university, and I spend most of my time in the university now, really are there to support that effort and improve that effort. So the university, I think, has to understand that our role, if we really are outcomes focused, we really are supporting those outcomes which are delivered through the healthcare providers and into the community. So you need to have that type of clear understanding about who does what. Then within the hospital, they need to trust. They need to trust that the university is here to help them with their outcomes and not with our own careers. And so, you know, the hospital has to actually make that leap of faith and say, okay, I've spoken to these people, they're for real, they're here to help us with our outcomes, they're not just feathering their own nest. The hospitals then need to respond to us when we put in ethics submissions, when we put in letters of support, and to contribute as much as they can from their very difficult budgets to things such as the MRFF or partnership grants. So I really think it's a part of our problem in Australia, I think, is that we haven't clearly articulated who does what, who's responsible for what, and what is the important thing. The important thing is community and consumer outcomes. And that unites us.
Yep. Mike, can I just ask you from your perspective? You've had a long perspective on this, travelled the world, and as well as North America. Tell us a little bit about that experience in terms of that question.
Well, I mean, you're hearing the same thing. It comes down to people, it comes down to trust, it comes down to transparency, it comes down to alignment. I think I was mentioning to you at the break, I was a nurse actually before I was a physician. And those cultures are very, very different. And sort of bridging even that amongst what we consider, you know, us versus them, I hate that, but I'll use it, even breaking down those barriers are just really important. And so I can't really add to that. It's the same theme about working together, start slow, build trust a little bit, you know, you will stub the toes, so that is, you're banking on the fact that you're going to make mistakes along the way and that's going to be okay. I really can't embellish it anymore.
Good, Louise.
Can I just add something, which is I think people in the hospital sector or in the health setting need to understand the financial drivers in universities as well, that the vast majority of researchers are actually funded on soft money through grants. They basically have to deliver on those grants. They're not there as a free team member. There has to be some money to actually pay for the staff. And not only that, there's, you know, hardly anyone has a long-term position, and those that do, a lot, you know, money's basically coming in from teaching. So even those with tenured roles actually have so many other things that they're trying to do. I found that in working with government, they will pay a large amount of money to the big four consulting firms. They sort of expect a $3,500 per day bill from them, but they somehow expect academia to come for free.
So, Greg, can I just ask you, that was not a segue into what, but that said, you spend a lot of time, and I know because you and I have sat down about the effort you put in to try and really articulate in your own mind what the missions were for MRFF. Why should they be important? You've spoken, you've reached out. You hear from the researchers because you perhaps one of the more active ministers of health who went out to find out. And then you also had the keys to the chest to impart a direction rather than a decision as to how it was spent. Does it break your heart when you see sometimes the gap that exists between the people who are really trying to do a lot of research, trying to answer the questions posed at the hospital, and for a systemic reasons, you know, there's this veil, this impenetrable mist at times?
I'm a little more optimistic than that, and
Good.
And that's because I had the privilege of seeing the collective results of all of the research efforts across the country over many years. And you know, Mike might have a differing perspective, but there's a very fair case to argue that our hybrid health system of the combination of the public and the private, which is less private than American, less reliant on private than American, less reliant on public than the UK, is arguably one of the best in the world. And then when you add in the research component, you can put, you know, the east coast of Australia, Boston, Cambridge, and argue that we're one of the three strongest medical research and treatment precincts in the world. So that's the good side. The other side is there's always competition for resources. We had about 132 billion of annual funding in federal health, most of which went to patients, but we then added a $20 billion corpus for research. So even that has to be peer-reviewed and competitive, and more people apply than receive grants. And that's a painful process, as everyone here will have missed out on grant applications under the Australian system, except for Mike, who will have missed out for grant applications under the American system at different times. But that process, it does drive quality, and there's inevitable disappointment, but it also is what underpins what I think is as good a research system as any in the world. The difference now is you've got sort of a series of streams of funding from Commonwealth to state to university, and then increasingly commercialisation options where you will see something such as the Walter and Eliza Hall Institute commercialising and licensing venetoclax for treatment of blood cancers. That in turn flows back to the research institution and the individuals. So you now have multiple strands of funding. It's never as much as the demand, but it's dramatically more than most of the rest of the world and dramatically more than it was.
Okay, so if we talk, I'm just waiting for someone to put their hand up. No, oh, here we go. Yes, please, Kaz.
Hi everyone. I'm Kaz Thursky. Can I ask the panel to comment on one of the sort of elephants in the room is around pharma and pharma's attitude to data ownership, particularly patients on clinical trials, when these patients are being managed in public hospitals, and that there's issues in able to use that data quite rightly to improve patient care. I'd really be interested in all your thoughts, because clearly that's one of the barriers that we face here at the moment.
Please, Claire.
So that's such a good question, and one that we're grappling with at the moment. So I guess we are in new territory, and the reason that we're struggling is because we haven't done this before. And whenever you are in new territory, it's always a good idea to remember what you do before you enter the new territory. So the approach that we're proposing is that that the use of real-world data for pharma trials could be subject to the normal HREC processes. The important thing is to make sure that pharma themselves is not actually accessing the patient data, so it would be commissioned research, if you like. So there's always the ability to undertake any type of normal research through HREC and data guardianship. What we do have to remember, though, is this is real-world data and not data specifically collected to answer a research question, and so the data custodian remains at the point where the data was collected. So the data could not be used for another purpose or possessed by the big pharma companies. It would remain the data asset of the data custodian.
It's actually the other way around. So we're having specific clinical trials, drug trials, where the pharma own the data because they've sponsored trial with the patient. Might be their fifth line of treatment and they've been in a hospital for 20 years, but suddenly we cannot include those patients into clinical epi or other research questions because for that particular point in time, they are a clinical research participant and pharma own the data. So it's the other way around.
That's
it's how we can,
really interesting.
Yeah, so it's the other way around because we should technically be able to use any patient's data.
Could I just ask on that point then, is it a question of an agreement or is it a framework?
So at the end of the day, I believe, and I think Jen and I have had these conversations, that actually consumers own their own data. You know, so I would argue, in fact, that it should be up to the consumer when and where and how their data is used. In the absence of that infrastructure, I would have thought that could have been negotiated. I mean, you look to me like you're a fearsome negotiator, though, so I'm concerned. I'm
She is,
concerned
by the way.
if you haven't been able to negotiate that.
It's a slightly dystopian situation, but it's like I actually think it does need to be a framework.
Yeah.
And that my impression is if a pharma is engaging a hospital, there need to be whether the data may be used for secondary use purposes to improve patient care. I think that should be the framework. Yeah. But it's still, I think many of us involved in clinical research know that it's often contract by contract by contract.
Correct.
And our poor legal team are absolutely exhausted by it because there is no clear way forward. So it's both ways.
Yeah, and I love that challenge. Perhaps we do need a framework that works both ways, because we've been concentrating on real world data, but you quite rightly point out that it's bi-directional. I love it.
So I think there may be a way through on this. Thank you for the insight. In the Commonwealth funding, obviously, we always very focused on the individual ownership, which goes to Louise's point. The compromise with My Health Record in getting the legislation through for the opt-out rather than opt-in was a time restriction on how widely the data could be used for research purposes. That was just, in order to get it through the Senate, that was the compromise I had to make. But I described it as pregnant data because it is usable and there is a pathway through. Now, in terms of the pharmaceuticals, where they're leading their clinical trials, I think the way to do this would be to broker a meeting with the Medicines Australia. So Medicines Australia is the peak body. They're very cognizant, both the chair and the CEO, very cognizant of their public duties. Anna Lavelle is the chair. She's Melbourne-based. And I think it would be possible, and I'm happy to assist in that, to drive a user agreement. So there's recognition of three things: their proprietary input, but the individual ownership, which is always paramount, but then thirdly, ancillary public benefit use. And so I think that is an achievable outcome through Medicines Australia.
Excellent, excellent. Cass, answered your question? There you are, a couple of votes for Blue Ribbon.
Your mission, should you choose to accept it.
Whether you choose to accept it.
Being recorded.
So we only have a few short moments, and what I'd like to ask very specifically is what model would work of an interaction between university and a health service when it comes to collaboration over data? That's a very broad question, but whatever paradigm you choose, can you give us a very specific model that you think would work? And you choose that.
Well,
It could be projects, for example. You might want to talk projects. You might want to talk about
no, look, I
translation,
think you need to do it on a fairly large scale and a large organisational scale, which probably in New South Wales would be like a local health district that covers a fairly large geographic area and multiple hospitals. Doing it on a project-by-project basis is just a complete waste of resources. There's examples of data accords that the Academic Health and Research Translation Centres, several of them, have developed. There's one currently being developed in Sphere, which is the centre that I'm part of, and that is really an agreement that's signed off by all of those, the participating local health districts and the universities, that sets out the sort of terms of engagement between them and starts to establish a foundation of trust about what can be shared. But clearly you sort of need to address the whole 5 safes framework in the way that you do it. So you need secure environments to access the data. You need certain levels of standards for training of the individuals who are accessing the data. You need agreements around the level of de-identification that's required, and when not, individual Human Research Ethics Committee approval is required. But I think these large-scale accords are a good place to start.
Yeah, the New Zealand Bureau of Statistics has one with the University of Otago, and they have exactly what you've just described. Please, Peter.
Peter Rogers, the hat I'm wearing at the moment, even though I'm a Melbourne University appointment is as Director of Research at the Women's, but I recently stood down after 3 years as Chair of the Victorian Hospital Research Directors Group. And to go to your comment, I think the biggest issue that came across all the research directors of the hospitals in Victoria, the research intensive ones, it's the lack of research infrastructure funding in hospitals. So I mean, a hospital, and we've discussed this, their core business is delivering healthcare, and their budgets include research, but in reality with the healthcare system, I mean, I think of our CEO. If a woman delivers on the steps of the hospital, she's going to lose her job. She's not going to lose her job if she cuts money out of the research budget. So, and I would support her on that. So you need to understand that the infrastructure funding to support research in hospitals doesn't exist. It does in universities, it does in research institutes, it doesn't in hospitals. And so even though the hospitals want to support some of this work, you know, the computer systems, we've got, I don't know, on whatever version of Windows came before, the one before that. We've got
Windows 3.
Yeah, I don't know. But, you know, you've got setups, and you talk about, you know, you've tried to download, I download, next generation sequencing data, and the computer just dies. So you've got a lot of infrastructure type related things which work against what we're trying to achieve. Having said that, some of the other suggestions, so embedding, I mean, I'm a basic scientist and I've been a research director in a hospital for 11 years. You need people that are bilingual, and they need to go both ways. I think that's been said already, but I couldn't support that more. The clinicians need to understand the basic research, and the basic researchers need to understand what goes on in hospitals and how to work in hospitals. That's critical. And I think there's so much to achieve if we can get that mix right.
Thank you. Mike, can I ask you from a very practical sense, the model that would bring university and the health providers together closer?
Yeah, and I'd take a contrarian view to what Louisa was saying. I think you heard the word bootstrap in the other panel. You know, think big, start small, and be successful. That's really the advice I'd give. Pick something that's meaningful, something that really has sort of the passion of both sides behind it, because passion will get you through a lot of fires a lot that are happening along. So, you know, pick something meaningful, make sure you're thinking big, but start small.
Yep. Claire?
I just wanted to respond quickly to Michael. That works really well when you have the infrastructure. And I think what Louisa's pointing at is like facilitating the frameworks and processes so that you can actually access the data rather than every individual researcher having to do that on their own is going to make it possible to have these collaborations grow.
Thank you.
I think have a very clear shared purpose, understand roles and responsibilities, and invest in the infrastructure.
How high do you think we should go in the institutional structure?
To the top.
Yeah, so it should sit at the top?
Absolutely to the top, because unless you've got alignment there, there'll be nervousness in the middle ranks. So you need absolutely very clear, well-articulated and public collaboration, trust and support, a clear understanding of roles and responsibilities and funding aligned with those roles and responsibilities, and an understanding that infrastructure invested, thank goodness for the MRFF, is needed to enable digital health research. If we were developing vaccines or drugs, we would have wet labs. We are developing digital health solutions. We need digital health infrastructure.
Thank you. Before I go to Greg, over to you.
Yeah, thanks. I just wanted to respond to the gentleman over there talking about the research infrastructure within the hospitals. And the Commission for Safety and Quality in Healthcare is now mandating a whole ramp of infrastructure and quality metrics within and reportable reportable measures within the research infrastructure of the hospital. I know, speaking from our hospital, that we do not have the computing systems that would come anywhere close to us being able to manage that external requirement. The other thing, so there's going to be a financial and a big impost on the hospital for that, just to maintain our current capabilities within this new environment. And the second thing I wanted to say is that I think at the moment we're all very much underutilising the EMR resources that we have in terms of enabling the research capability of our organisations. So all of our systems, whether it be Cerner or Epic or any of the others, is more than capable of identifying digital phenotypes on patients, enabling the identification of patients who might be suitable for particular research projects, enabling lists of those things of those patients to be put to the research coordinators, managing all the documentation and so forth within the EMR and having it reportable out. So I think that whilst Epic and Cerner certainly have modules for these things. I know in the Cerner environment they're probably haven't been invested in as much as they might have been in the United States. But I think there's a huge capability gap that we have that's within that close of actually being sustainable and manageable.
Thank you. Greg, can I just ask you just to close it off for us, the model that would work from your view?
Sure. Firstly, what's been the biggest barrier? The biggest barrier is privacy concern. Now, you can talk funding, but the real barrier is there will be people, whether it's from one side or another, who will be very concerned. We had a massive fight to have a national health record. Just that was opposed by a very large number of people on the basis that this would be exploited or it would be used for implantation of nanobots, I kid you not. And there are people in the parliament who said that. So you need to keep in mind that's the concern that has to be addressed, because the researchers' response is often, I know it's fine, we've got things in place, but to start from that threat to your research. So having said that, I think that the pathway that I would recommend is very similar to what Louisa was proposing, but I think it can be done at a slightly bigger level, and that is research data use agreements, both with the Commonwealth and the universities and the medical community, and with the relevant state departments of health as umbrellas for the respective local hospital districts and LHNs as well for the or PHNs as well for the primary health. And the way to do that, it might be for your two centres, Louisa and Wendy, to be the sort of chief negotiators on behalf of the research community with the Digital Health Agency at the Commonwealth level and with the state health departments. So you have critical counterparties. Now people would have to sign on to and adopt the protocols and be reviewable to make sure that they can meet the standards, not just say they'll meet the standards. But that's how to open the pathway, I think, to greater systemic use and greater access to de-identified, what I call population health data. But we're a bit more familiar with population health data as a country and more comfortable post-COVID. And so I think those frameworks are there. The natural counterparties, I'm suggesting the two centres might be the leaders of the negotiation. Bringing on board universities who would opt in themselves and then sign up, and you'd have the universities do it rather than have to go department by department. And you do one with the Commonwealth and one with each of the states, but a model agreement with the first state. And you could take that to the Council of Health Ministers as a proposal, with perhaps either the New South Wales or Victorian Health Minister as the champion for it.
Thank you very much. So there you have it, folks. What a lovely session we've had this morning. So join me in thanking our speakers.